Hopefully everyone can hear me and can see my screen. Rebecca, is that true?
Yes.
Great, fantastic. I usually can't go one Zoom call without inadvertently talking while on mute or failing to actually share screen. So I'm glad that we've gotten off to a bit of a seamless start. I'm really happy to be here, and I would just like to reiterate first and foremost that to all of the attendees today, if you haven't had a chance to see Dr. Nunki Rai's presentation on uprooting medical violence, to please make sure that you do. It was incredibly well done. It's going to be some tough shoes to walk in today. I wanted to start off just by highlighting one of the quotes from a Safer Supply program that I am clinical lead for here in Victoria. Right at the onset, we did a community engagement component where we asked people who use drugs and people who are prescribers and people who work in the medical profession about what they needed to see from a safe supply program. And one of the very first learnings we got was that remember that ultimately when people use drugs, they generally want it to be fun and enjoyable experience while they're using them. Any barriers to the actual enjoyment of the substances are barriers to people using the program. That's a really important thing to try and center ourselves on as we move through this presentation today. Now, with that being said, before we get started, I would like to acknowledge and recognize that colonization and the institutional oppressors that continue to permeate in our society have dramatically impacted Indigenous people who call this land home. The host of disproportionate impacts towards Indigenous people are far-reaching and span generations. There's a link between colonization, which is fundamentally a process of violence and disconnection that operates on multiple levels, both currently and historically, and the topics that we're here to discuss today, namely the war on people who use drugs on the land commonly referred to as Canada, and the disproportionate impact of criminalization and the fentanyl poisoning crisis on Indigenous people as an ongoing impact of colonization. A land acknowledgement is not enough, not even remotely, when it comes to eliminating structural and historical barriers erected through colonization, but it is a small step towards humility and collaboration. It's with that spirit today that I'm very privileged as a white settler on stolen land to be speaking to you today from the intersections of Malahat First Nations and the Cowichan tribe. I'm privileged to do work on Lekwungen speaking people's traditional territory, as well as that of the Wasanic people and Suk First Nations. And I'm incredibly grateful to be able to do this work and to be able to present to you today. I also want to acknowledge the value and role that people with lived and living experience of drug use have played in this overdose crisis and this fentanyl poisoning crisis. They've borne the brunt of all of the risk assumption, and they've been the reason why we've been able to innovate so quickly and to take risks in terms of implementing take-home naloxone programming and supervised consumption services. And they continue today to push us and to teach us so that we can do better work. It's without their generosity that this presentation would not be possible. Today, I've been tasked with discussing a wide range of topics, ranging from an introductory explainer of harm reduction to its underpinning philosophy of care and how that bridges into safe supply and what safe supply is. And then we'll be concluding today with talking about the program that I'm clinical lead for, which is the Victoria Safer Initiative, a flexible harm reduction model for pharmaceutical alternatives to the toxic drug supply. There will be some discomfort and tensions today because we're going to be talking about the tensions between addiction medicine and harm reduction, and there are many. Even while exploring the principles of harm reduction, you may find yourself a bit challenged. And so it's important to acknowledge that when we talk about the harms of medicalization, the harms of the medical institution of nursing, that it's not about you, it's about the history and the traumas that people have experienced and the work that we need to do in order to ameliorate some of those harms. A little bit about myself. I'm a registered nurse. I've spent the bulk of my background working in harm reduction And I started my career at Streetworks in Edmonton as a student in my final preceptorship, and then I got hired on to complete the bloodborne pathogens programming through the Public Health Agency of Canada. And I got an immediate crash course into harm reduction and what it means to work under anti-oppressive practices. Since that time, I've worked on the harm reduction team in Calgary, the STI clinic, implemented HIV programming in rural Alberta, take-home naloxone programming and supervised consumption services in southern Alberta. And when the new Alberta government came into power, the UCP came into power, and they defunded our supervised consumption service, I made the move back to British Columbia, which is where I was born and raised. And since that time, I've been the project manager for the Provincial Peer Training Curriculum Project. And most recently now I'm the clinical lead for AVI and Solid Safer Victoria initiative. I'm incredibly passionate about this work, and as such, I'm incredibly annoying to be around, and I'm a very critical person. I'm not a fun person to bring to parties. However, I'm extremely excited to be speaking to you all today about this very important topic. We can't talk about safe supply and harm reduction without talking about the toxic drug supply and the impacts that the toxic drug supply has had on people who use drugs, both in British Columbia and abroad in so-called Canada. We just recently passed 5 years of a public health emergency in British Columbia. That's over 2,000 days that a public health emergency has been declared over the toxic drug supply. And so this is far from a new crisis. However, at the onset of the pandemic, those of us who were working on the front lines, myself included, I was working in one of the state-run homeless encampments that had been developed as a response to the pandemic. We saw an immediate shift and increase in the volatility of the toxic drug supply yet again. In March and April of 2020, overdoses began to skyrocket again in British Columbia, and there's many reasons. It's multifactorial as to how this happened, but from a macro perspective, changes to the borders, regulations, all of that shifted drug supply. But then on the meso and micro level, we saw the restriction and closure of vital harm reduction services and overdose prevention services. We saw people pushed into encampments and being told to isolate and to quarantine, and all of that meant increased risk for overdose. And in the Overcheck week in April, we lost several people to overdose death, and we also experienced multiple days with 7+ overdoses during that day. And what we learned was that there was a shift in the concentration of fentanyl that was available on the streets, as well as the adulteration of benzodiazepines and other synthetic benzos. Synthetic sedatives, including xylazine, were incorporated into the drug supply, and the risk just shot up exponentially for people. Now, we are, just released July 2021's numbers, and it was the second to worst month on record in British Columbia, with 184 deaths recorded. 72% of those dying are aged 30 to 59. And there's been a significant increase in terms of the number of people who are dying, but also the number of people who are dying outside, who are dying in alleyways and parkades. And it's been an incredibly challenging time, as many of you can probably empathize with. We're currently at a pace where we're losing 5.9 British Columbians every single day. But during this time, we also noticed that there was BC's first attempt at a safe supply announcement. And what we saw was, which is now being referred to as risk mitigation guidance prescribing, and here in Vancouver Island, it's being referred to as pandemic prescribing risk mitigation. We saw this new guidance come out that essentially gave the okay for the prescribing of pharmaceutical alternatives to the toxic drug supply. Myself and another nurse who were working in the parks were over the moon, thinking that this was it. This was safe supply, and this is what we needed in order to help people to make sure that they could stay safe, that they had agency of choice, that they would be able to reduce reliance on the toxic drug supply, and ultimately, the most important thing, that less people would be dying. But what we learned really quickly was that the first round of safe supply through BC was full of barriers, and that it was pretty hastily thrown together. And we learned firsthand some of those barriers and some of those issues simply by trying to connect people to a safe supply. Myself and that other nurse would be working with people in the encampments and doing intakes and phoning doctors and trying to advocate for people to get onto a safe supply. And the first thing we noticed was that there was an extreme level of prescriber gatekeeping that had occurred. Essentially, if people already had a family doctor or if they had an OAT provider, that there was no way that we would be able to work outside of that existing prescriber. I remember trying to support someone who was quite young and vulnerable in the park, and her only doctor was a physician who worked at a recovery center. And when I called him to talk about a safe supply, he laughed at me and said he's a recovery doctor, not a dilaudid doctor. And essentially we were stuck at that point. We didn't know what else we could do for this person. There was a shortage of doctors in Victoria, so it's not like we could just fire him and move on to a different prescriber. And ultimately it took weeks before we were able to connect this individual to a safe supply. So our first little pause and reflection today is to really think about the harms of incrementalism and half measures. And so I'll post some questions just for you to reflect on, and hopefully we'll have some time at the end of today to have a conversation and to hear questions and feedback from you. But what have been your experiences to date supporting someone to access a safe supply? What are the biggest challenges you see with a safe supply? How do we take vital steps forward towards an accessible and effective safe supply? It is my hope through this presentation and through hearing from experts like Dr. Nanki Rai, and most importantly, through meaningful partnerships and engagement and consultation with people who use drugs, that we can find pathways forward together. And that is really the purpose of these presentations. To answer some of these questions and to truly experience forward progress in addressing the toxic and volatile drug supply, we need to situate ourselves firmly within a harm reduction approach. There's a learning curve in harm reduction, where someone who is new to the concept, new to the workplace environment, sees harm reduction exactly as shown on this screen, as a set of services or initiatives that are aimed at mitigating potential harms for higher risk activities. In this stage of the learning process, you'll hear people parrot statements like, it's important to meet people where they're at, or perhaps you'll hear them liken harm reduction to a seatbelt or a parachute or a bike helmet. You may even hinge your understanding of harm reduction on simple concepts like the one shown on the screen. Life carries risks, and certain activities can heighten risk. One can attempt to stop that activity, i.e. abstain, or one can try to make that activity safer. And if this is the culmination of your knowledge of harm reduction, then we do have some work to do because it's incredibly superficial. The truth is that we just described ways in which harm reduction can be delivered, but harm reduction is much more than a series of services and interventions. Harm reduction is an underpinning philosophy of practice and warrants investment in every facet of health and social services. From a public health perspective, harm reduction focuses on risk mitigation, but from the perspective of people who are victimized and oppressed by laws and policies rooted in discrimination, harm reduction is the radical redistribution of power and resources to those less privileged. It's about addressing root causes and dismantling power structures that perpetuate harms. There's an excellent video called Taking Care of Each Other, and it's by the First Nations Health Authority. And from that video, which is only 3 minutes and 30 seconds long, so I'd encourage people to have a look at it, there's a great quote about Indigenous approaches to harm reduction, and that is, mainstream harm reduction practices such as naloxone distribution and opioid substitution therapies have been proven to save lives. However, they are narrowly focused on substance using behaviors and do not address the broader social and system-wide issues that contribute to and intersect with substance use for Indigenous people in the first place. For Indigenous communities, harm reduction is reducing the harms of colonization, and that means that Indigenous harm reduction is not tethered to the use of substances. Instead, Indigenous harm reduction is a way of life, embedded within traditional knowledge systems that see the spiritual world, the natural world, and humanity as interrelated. Given that these knowledge systems and the way of life they have given rise to have been disrupted by historic and ongoing impacts of colonization, Decolonizing policy and program environments to support the restoration of these relationships is critical to restoring the health and wellness of Indigenous communities. Prohibition of substances and criminalization of people are systemic forces that oppress people who use drugs, i.e. the war on drugs. As people doing harm reduction work, we have to understand that we are working against the backdrop of this war, which is really a war on the people. And as we all know, is killing people in unprecedented numbers. The ongoing criminalization of people who use drugs pushes people towards harm in multiple ways, and indeed represents one of the biggest association of harms with drug use, which is not the drugs themselves, but the policies that make them less safe. Our drug laws still make criminals out of people who use certain substances, which only reinforces the pervasive value system that regards harm reduction as enabling people to behave in certain ways. People use substances for a number of reasons, including pleasure, fun, spirituality, pain management, personal growth and creativity. And these individuals still face harms related to the fact that we criminalize some substances over others, which feeds unregulated markets and an unpredictable supply that can easily become toxic and dangerous. What you're seeing on screen here is the iron law of prohibition, which essentially says the harder the enforcement, the harder the drugs. And so it is our prohibitive nature, both in law enforcement and in the medical system, that continues to increase risk for people who use any substance. Canada's first drug prohibition was directed at Indigenous people. Alcohol was first introduced to Indigenous people by British, French, and US settlers through colonization. But when colonizers began to forcibly convert Indigenous people to Christian relations, morals, and values, they also advocated abstinence and believed that prohibition would mean there would be less interracial mixing between white and Indigenous people. While alcohol prohibition had a short history in Canada, it was imposed on Indigenous people for over a century. Prohibition served as a legal mechanism to control Indigenous people and nations right up until 1955. You're looking for more information on this because this is a very cursory glance. I would really encourage you to read the Drug War Reading List by Zoe Dodd, as well as the Illustrated History of Prohibition by Susan Boyd, both of which are excellent resources that I would encourage folks to invest some time into. Harm reduction can be traced back to people organizing in the 1960s against illegal suppression of drugs and to places in Western Europe, the UK, and New York. An example of the earliest harm reduction programming was the opening of a needle exchange program in Amsterdam in 1984. And essentially, it was a form of community care because people in the community were worried about injection-related litter and growing concerns about this new virus, HIV. And so in response to the only pharmacy that would provide needles shutting down, drug users organized to set up programs where people could not only access needles, but also bring their used needles in to reduce the amount of garbage that was left around the city. So as we continue to move about this, I'm going to prompt questions so that people have an opportunity to learn more and to reflect on their own practice. What are the obstacles to harm reduction practice in your place of work? How might harm reduction be further incorporated into your work? And how do you practice harm reduction in your workplace? People who work in harm reduction often do so because they see some of their personal values and principles reflected in the values and principles of harm reduction. Whether you're someone with personal experience of drug use or you're coming to this work without that personal experience, it's the values of harm reduction that can often unite us in solidarity, and that's key to the health and future of harm reduction as a movement and as a practice that is rooted in our hearts and not just in our heads. Too often, harm reduction is divorced from its radical potential as a social justice tool. When we lose sight of the deeper meaning of harm reduction and the values at its core, we risk relating to one another in ways that are not really in line with harm reduction practices at all. We're going to spend some time talking about the principles and values of harm reduction, namely because it's important that we ground ourselves in these principles as we move forward and talk about safe supply. Harm reduction is based on a set of principles and concepts that make up the foundation of the philosophy, the movement, and the practice. The 9 principles that we're going to go through come from the Harm Reduction Coalition and from the Harm Reduction International. They've been consolidated and they're summarized and less jargony now, so that they're a little bit more accessible to folks. The first principle is that drug use is a human behavior that many people across the world are unwilling or unable to stop. And the second is that people who use drugs do not lose their human rights due to their drug use. We are entitled to the rights to life, the highest attainable standard of health, social supports, privacy, freedom from arbitrary detention and degrading treatment, and others. Treating people who use drugs, their families, and their communities with dignity and compassion honors their human rights. The next principle is essentially that people take drugs for a number of reasons and in many different ways. There's a number of different spectrums and continuums that exist, and all of them are equally problematic, even just for the use of terms like problematic drug use. However, it's important to understand that people use episodically, people use casually, people use recreationally, people use daily, and there's a whole myriad of reasons as to why people do use, and we need to respect and honor those. The fourth principle is that harm reduction is evidence-based. Harm reduction policies and practices are informed by a robust body of evidence that show these interventions have strong positive impacts on individual and community health. Harm reduction is also committed to meeting people where they're at. You see that term again, without judgment and without the use of stigmatizing language that perpetuates stereotypes and creates barriers to health. Harm reduction is concerned about quality of life for everyone, not necessarily ending drug use. And the sixth one here is incredibly important as we move forward in our conversation about safe supply. And it's that options for prevention, care, and treatment must be evidence-based, high quality, and non-coercive. Many people who use drugs do not need treatment, and those who want support such as treatment should have access to options that do not require abstinence. This is a vital principle and one that we've already seen violated in a number of safe supply initiatives. Can you think of an example of a non-coercive service? How could we expand treatment options to be more diverse and accessible to a broader range of needs? The seventh principle is that people who use drugs must be involved in designing, implementing, and evaluating programs and policies that serve them. Meaningful involvement of people who use drugs in designing, implementing, and evaluating programs and policies that serve them is central to harm reduction. Nothing about us without us is a commonly used phrase, and it's something that affirms that people who use drugs are the experts in reducing harms associated with toxic drug policy. The eighth principle is that harm reduction is rooted in a commitment to social justice and addressing inequities that exclude people who use drugs from the supports they need. And finally, harm reduction challenges policies and practices that cause harm. Many policies and practices intentionally or unintentionally create and exacerbate risks and harms for people who use drugs, including criminalization of drug use, discrimination, abusive and corrupt policing practices, restrictive and punitive laws and policies, and the denial of life-saving medical care and harm reduction services. This movement asserts that non-judgmental and practical integrated services can reduce many of the harms associated with toxic drug policy, many of which are not specific to the drugs themselves, but rather they stem from a lack of legal, unadulterated drugs and access to new equipment and other means in which people can keep themselves safe. Drug prohibitionist policies and laws are seen as negatively contributing to and exacerbating the factors they claim to actually reduce. So how do we take these value-based principles of harm reduction and weave them into safe supply? How do we challenge our own institutional and organizational power structures to foster equity and agency of choice for people who use drugs? These are some of the questions we should be reflecting on from the remainder of the presentation. And hopefully, as you set out to do the vital work that you do, you'll continue to reflect on them. So now that we understand harm reduction as an underpinning philosophy of care, we can talk about what a safe supply really is and the potential public good that can be done through an effective safe supply. Safe supply at its core is about agency of choice. Many equate it to the provision of pharmaceutical alternatives to the toxic drug supply, but that's only one iteration of a safe supply. And it's actually the medicalized iteration, and the one that many of us find ourselves working in right now. What's important to understand, though, is that safe supply options range on a continuum from medicalized models to compassion clubs to regulated dispensaries to the Drug User Liberation Front handing out tested and unadulterated drugs in the middle of the downtown East Side. There is no panacea for safe supply, and the most effective model is actually the anti-scalable model. Nothing more, nothing less than people, regardless of where they're at in their lives, being able to locate a source and access drugs that are guaranteed to contain exactly what they're seeking out: autonomy and the right to choose. And it includes all drugs, including managed alcohol programs. So what are some of the things that safe supply has the potential to do when delivered appropriately and effectively and in a culturally safe manner? Well, most importantly, it has the potential to reduce overdose deaths, to reduce deaths through the toxic drug supply. And that, of course, is one of the main reasons why we're all here today. There's also less police intervention. Through the provision of a legal and regulated supply of drugs, we reduce the likelihood that people will be unjustly criminalized for their substance use. When we work with people who are using drugs and who are able to access a safe supply, they talk about having more balance in their lives. They talk about less chaos and less reliance on the street economy. They talk about being able to prioritize and focus on other things that are important to them. There is, of course, less COVID-19 risk as well with the provision of a safe supply, because it means that less people have to spend their day hustling and interacting with multiple people. Here in Victoria, this is incredibly important and timely because we're in the midst of a significant outbreak amongst Victoria's homeless population. And recent news showed that there was around 225 people who are accessing shelters or experiencing homelessness who are COVID positive. And many of them were provided with very few options in order to access a safe supply while they tried to isolate from a potentially deadly virus. Safe supply is also cost effective because it's the reduction in overdose and police intervention and incarceration and disease transmission. It's also a gateway for people to access other forms of care. With so much mistrust, warranted mistrust between the healthcare system and people who use drugs, safe supply fosters positive relationships with service providers if that's something that the individual wants to access. It also reduces stigma because it takes the criminality out of substance use, and criminalization and prohibition are at the heart of stigma. It also means people experience less withdrawal, less cravings, and of course, it is a potential for a gateway to change, and not a gateway for change for the individual, which might be something that they want, but what I'm talking about is systemic change, that it is another necessary step towards decriminalization of people who use drugs, which of course we know is so vitally needed at this point in time. Now, there are also different models within the medicalized constructs and categories for the delivery of safe supply, and this is defined by Health Canada. There is a traditional, enhanced, and flexible model. The project that I work in is intended to be a flexible model for safe supply, but what we typically see right now are traditional and enhanced models, which are mired in medicalized practices and addiction medicine practices. Traditional models look like OAT or IOT. They're incredibly protocolized, and oftentimes people are tethered to their programs. Enhanced models include things like tablet IOT programs, including like at the Molson overdose prevention site. And then flexible models, the characteristics of those are supposed to be low threshold, harm reduction and public health informed, embedded in primary care, consumption sites, overdose prevention sites, consumption and treatment services or housing, with pathways to health, social, and addiction treatment services that are centered around the individual's own priorities and goals. A few months ago, I tried to work with a couple of organizations to create a guide to help people access a safe supply here in British Columbia. The problem is that there is a number of programs, but those programs are low capacity and they're difficult for people to access. And so we wanted to create a template or a roadmap that people could use if they were going to try and navigate accessing their own physician, or if they're going to try to self-advocate. And essentially, what we're looking at is that it's very high barrier when you look at this. And if someone is trying to help an individual access a safe supply, it can be incredibly overwhelming. I recall when I was first working in the homeless encampments and the risk mitigation guidance documents came out, and there was another organization that had put out a how-to guide on how to access a safe supply. And it was a very basic walkthrough. And what it actually did was encourage individuals to call their own prescriber and let them know that they would like to access a safe supply. And what people learned really quickly was that that was incredibly harmful and traumatic for people to experience, because these individuals had long-standing relationships with tenuous amounts of trust with their service provider and with their prescriber. And they had to call and expose themselves and say, I'm still using street vent. I'm still, I'm looking to access a safe supply. And what actually resulted from that was that some people had a reduction in their carries of their OAT. Some people actually got punished for trying to reach out to their prescriber and trying to be open and trustworthy with their prescriber. And so what we've tried to do moving forward is that we make sure that nobody has these phone calls alone, and that we make sure that we are not expecting the individual to contact their doctor on their own, and that we arm people who are going to act as advocates with as much information as possible so that they can challenge the paternalism that exists within a lot of these guidelines. These handouts and a number of other handouts are available, and I believe were sent out to the group ahead of time, but I'll leave it to Rebecca to explain how people can access those moving forward. So we're at this uncomfortable intersection, and this may be uncomfortable for some people to hear, but the paternalism that's laden within addiction medicine is actually one of the biggest reasons why safe supply is not accessible right now to people. In addiction medicine and through risk mitigation guidance prescribing, what we've seen is that doses are often too low to have the desired effects, and that clients are often expected to take opioid agonist therapy as a contingency to access their safe supply. And so if you reflect back on the principles of harm reduction and that options for treatment and prevention need to be non-coercive, you can see right there how we've already missed the mark. Medications often don't provide people with essentially what they need in order to meet their needs. And that's particularly highlighted in the fact that there remains very few options for people who smoke their drugs. And yet here in British Columbia and abroad, people who are dying the most by overdose are people who smoke their drugs. We also see a complete obsession with urine drug screens, missed doses, and most importantly, what we've noted over the last year and a bit of trying to deliver a safe supply is that there is an incredibly flawed use of metrics for evaluation and for measures for success. And essentially, many practitioners and prescribers will not take patient-reported self-benefits as a marker for success. They won't take someone saying, I've reduced my street use by 50%, or, hey, I've stopped injecting and smoking and I only orally consume my pills. These aren't measurable and objective in the eyes of a lot of prescribers. And so what people use for measurements of success are urine drug screens, treatment adherence, follow-up appointments, and that is a really superficial way of looking at the impacts that a safe supply can have for an individual. And then ultimately, through an addiction medicine model, we see that clients are frequently lost to contact and prescriptions are often being taken away or with missed doses. And there's a profound lack of carries that are available to people. And so people continue, despite being offered a safe supply, to be handcuffed to daily witness consumption or to daily dispensing from a pharmacy, despite the fact that people who use drugs are very adamantly saying, we don't want this, this is not our safe supply. So why isn't it working? Well, currently there is the wrong type of drugs being offered. There are many people who benefit from Dilaudid and other tablet medications, but currently a recent presentation from Substance, which is the Vancouver Island Drug Checkers, showed that if somebody is saying that they're using about 5 points of down a day, that could be the morphine equivalency of 1,950 to 7,400 milligrams of morphine. And when we're talking about 8 Dilaudid 8 milligram tablets, we aren't even scratching the surface of people's needs. There continues to be poor consultation and engagement with people who use drugs. And I'm really reassured that we are having these meetings, and that I'm hoping that we get the opportunity to hear from people who use drugs moving forward in these educational series. Again, it's being delivered through an addiction medicine model, and a lot of people are being required to go on to OAT if they want to access their safe supply. And many people have had very bad experiences with their OAT. There's risk aversion, ideology at play, no considerations for people who smoke their drugs, lots of requirements for urine drug screens and daily dispensing, which is a very high barrier for people to access. And then it becomes disparately inequitable when you talk about people's access in rural and remote communities. So as long as safe supply is framed as treatment, it will always be mired in control and surveillance of people who use drugs. I once had a doctor a couple months ago say to me, I wish we could just go back to what used to work, when he was talking about safe supply. And so his belief was what used to work was strictly OAT. And the fact that that is even a belief that that is something that was working amidst this ongoing overdose crisis, then right there you see some cognitive distortions. You'll also hear people say, I agree with safe supply, I just don't think it should be in my hands. Or I can go to a liquor store and buy a bottle of wine. Why shouldn't we just do that? Well, the fact is that we can't right now. There's too many regulatory barriers in place. And while we need to continue to work to dismantling all of these structures so that people can access a safe supply in the same way that someone can access a safe supply of alcohol, right now we need prescribers. And we need prescribers to assume risk, and we need prescribers to step outside of their comfort zone so that we can continue to move along the continuum to something that is going to be more effective and more accessible to people. If you think about the evolution of cannabis, at one point in time that had to go through prescribers' hands, and it made absolutely no sense, but we had to do that first before we could get to a regulated dispensary model. You'll also hear people say there's no long-term evidence available to support. And the fact is that, yes, these are novel concepts. We can't wait amidst a public health emergency for a few low-capacity pilot studies to develop evidence. We cannot continue to study these issues to death, and we cannot subject individuals to randomized control trials to see who lives and who dies. Our evidence must also be balanced in real-time feedback from people who use drugs. So what you see here in this confirmation bias Venn diagram is the basis for the cycle of inaction. A hastily thrown together medicalized withdrawal management tool for safe supply has failed to launch in BC. And that is exactly what detractors of safe supply need to hear so that they can abandon this approach before it ever gets the chance to do good. It is exactly how incrementalism kills. The truth is that we're all somewhere at the very onset of clinical delivery models to just starting to cusp perhaps on harm reduction. We are at that uncomfortable intersection of addiction medicine and harm reduction. And it's here where we must sit and move past that discomfort, where we challenge entrenched policies and procedures so that we can move towards the real end goals of decriminalization, legalization, regulation, reconciliation, decolonization, and drug user liberation. This graphic is also available to anybody who's interested in it. It's something that I put together just to show a little bit of the different iterations and versions of a safe supply that can exist. And the truth is that, as I've said before, the anti-scalable model means that all of these options are available to people, because there will always be a need for a medicalized model for a certain demographic of individuals, depending on what their priorities and goals are. But there also needs to be accessible dispensaries and compassion clubs. There also needs to be people handing out safe and regulated supplies. And we need to see all of these fully invested in so that we can actually see progress in this devastating drug poisoning crisis. For the final part of today, I'm going to talk about the Victoria Safer Initiative, which is the program that I'm the clinical lead for. We received funding from the Substance Use and Addiction Program from the federal government in July of 2020. And our goal, our mandate was to develop, implement, and evaluate a flexible model for safe supply over a span of 10 months. And that's how long our funding was for. And so we did our best to be both flexible to implement services right away and to gather feedback and engagement and consultation from people who use drugs all simultaneously so that we can continue to adapt the program as we move through that space and learn what's working and what isn't. At the time, we only had the capacity to do it via outreach. And so our team worked across 12 different homeless encampments in Victoria. And it started off with myself and a systems navigator and an experiential outreach worker, connecting with people in parks, doing intakes and phoning doctors and asking them and advocating for them on an individual basis to offer a safe supply. And as our program developed, we actually brought on 5 doctors of our own. We rewrote our own clinical prescriber guidance, and we challenged a lot of the barriers that existed within the risk mitigation guidance documents that came out of British Columbia. First and foremost, that included adding Oxycodone to our list of frontline options for prescribing, because we knew anecdotally from people that we worked with in the community that folks were able to smoke their oxys, and we knew that there needed to be a smokable option for people. We're flexible and we respond to trends. Over that 10 months, we wrote our own prescriber guidance, we added oxys, we embedded nurses within an unsanctioned overdose prevention site in the middle of a park so that we can do intakes for safe supply. When we encountered individuals who were sleeping in parks who had accessibility issues and were struggling to get to the pharmacy every single day, we developed a medication delivery program that focused specifically on individuals who had accessibility issues, and we brought the meds to them. That's what people mean in harm reduction when they say meeting people where they're at. And we continue to adapt and evolve based off of the feedback that we received. Our staffing model is one that centers people who use drugs and also leans forward with people with lived and living experience in order to bridge those trust issues between service providers like myself. We have nurses, outreach workers, physicians who operate under a medical light model and primarily rely upon the nurses and protocolized structures in order to prescribe. And we have systems navigators who about 90% of our participants are engaged with on things like access to housing options, income supports, legal aid, all of the things that may hinder someone's ability to access a safe supply, we attempt to address. Even if someone doesn't have medication coverage, we cover the costs of those medications while our systems navigators work to get the individual coverage so that there is not a gap in people being able to access their medications. Simultaneously, we were also working with the University of Victoria and the Canadian Institute for Substance Use Research to do a service user design engagement process and concept mapping. We completed 7 focus groups with 35 individuals, and the groups were cohorted into people who are sleeping in parks, people who are accessing hotel sites, people who inject their drugs, people who smoke their drugs, people who identify as First Nations, Indigenous, Métis, and people who work in the sex work industry. And we asked them all one centralizing question, which was, I would access safe supply if. And from those focus groups, 6 different clusters were developed. And one of them was the right dose and the right drugs for me. Another one was that people wanted a safe, positive, and welcoming space to be. Another different concept was that people wanted safe supply and other services that are accessible, i.e. they wanted to be able to access a systems navigator. They wanted to be able to get help with their legal supports. It became much more than just offering a prescription to individuals. People want to be treated with respect, and they wanted to be trusted with their prescription. They wanted to be able to easily access their safe supply. And most importantly, people wanted a program that could help them function and improve their quality of life as defined by them, that their priorities and their goals were centered in plans of care. Throughout all of this time, we continue to develop and change our prescribing practices and continue to develop and change our programming based off of this feedback that we received. We also put together a practice brief because part of the work that we do at SAFER is making sure that we protect and support our prescribers as much as possible to do this really vital work. We understand that no matter how much we try to make it a medical light model, it still is prescriber driven. And so we try to do everything we can to make things safe for our prescribers. And to that end, we wrote a practice brief, which incorporated the outcomes of our program to date, which incorporated the concept mapping data, our community engagement data, and it also coupled it with an ethics analysis that was commissioned by the province of British Columbia. And from this ethics analysis, we learned really quickly that, ethically speaking, there was an impetus, a requirement for prescribers to do this type of work. And some of the quotes from this ethics analysis include, furthermore, as has already been pointed out, even if diversion were to occur, if witness administration was not required, it would reduce the overall reliance of other drug users on a toxic drug supply. A healthcare professional would have an ethical obligation to prescribe a medication that would allow the drug user to avoid having a recourse to the toxic drug supply, rather than the professional insisting on only prescribing on the condition of engaging in individualized medical treatment that extends beyond what the individual specifically requests. Lastly, if the data demonstrates that prescribing reduces the risk of harm, failure to prescribe could violate healthcare professionals' ethical obligation to the patient. So that ethics analysis, coupled with the practice brief, is all available as well, and has been included in the package that I sent off to Rebecca. What have our stats shown over the last year? Well, by the time we made it through our 10-month marker, SUAP had renewed our funding and given us 2 more years of funding. And at that point, we knew that we needed to shift the work that we were doing and that we needed to be able to offer people substances beyond the tablet options because we were not meeting people's tolerances. We were not able to keep pace with what was available on the street. And so in addition to having the outreach model and continuing to support people who are accessing Dilaudid or Oxycodone or Dexedrine or Ritalin, we also opened a clinic. And in this clinic, it's a refurbished, rehabilitated pizza restaurant that's been turned into a medical clinic in a very short turnaround. And through this clinic, we've started offering 3 fentanyl-based products in order for people to access, one of which is a fentanyl patch program. The next is an injectable or sublingual sufentanil program. And the other one is a dissolvable effervescent fentanyl tablet program. And what we've learned really quickly is that there's a very high retention rate, because what we've done in our program now is that we've created a continuum within our own program. And so if people aren't having their needs met through the tablet options, they've got options that they can come into the clinic for. If people are experiencing a lot of chaos in their lives, they can start with the sufentanil program, which is very low barrier, and people can miss up to 29 days worth of doses and still come in on day 30 and receive a dose without having to jump through a bunch of hoops. So over the 1-year anniversary, because this is stats up until July of 2021, we've had 150 total connections to Safe Supply, and we're currently doing active case management and support with 98 participants. Lastly, we've also done a lot of learning over this time, and we've heard from our staff and we've heard from participants. And so the Safer Victoria initiative has produced what we call the Safer Top 10 Lessons Learned, trying to deliver safe supply amidst dual healthcare crises. And the first is that the drugs need to match the needs. Drug tolerances are outpacing the effectiveness of current pharmaceutical alternatives without options that include powdered fentanyl, diacetylmorphine, and other formulations that can match potency and preferred route of consumption. The illegal supply will continue to prevail. The second lesson is that measures for success need to include self-reported benefits. Participants tell us that they're using less street fentanyl and feel better for having an access to a safe supply. They tell us they have more stability in their lives. Many report decreased reliance on the street market. Some have stopped using fentanyl altogether, and others tell us that they experience less dope sickness and withdrawal. That should count much or more than a urine drug screen result. People are experiencing benefits from the provision of pharmaceutical alternatives. I had one individual contact me and say, yeah, I'm using a lot less, but I just wanted to let you know that I've reconnected with my family and they're letting me stay with them again. And then their mom actually talked to me on the phone and learned about Safe Supply and was so grateful that they were able to connect with their child again. The third lesson is that people who use drugs are the experts in their own experiences and relationships with substances. Decision-making without proper collaboration with people who use drugs is still the norm. This results in highly clinical programs that don't match the diverse needs of people who use drugs. The fourth lesson is that service delivery models that are flexible and lead with people with lived and living experience are integral in fostering trust and connections to care. The fifth is that the provision of pharmaceutical alternatives through an addiction medicine model is limiting the impacts in reducing overdose prevention and harm reduction. Number six is that people who use drugs take care of each other. And when then drugs are shared, sold, and exchanged, i.e. diversion, it is often about providing care and meeting basic needs. Many participants with SAFER have actually self-referred after accessing diverted Safe Supply, because it was a gateway for them to seek out their own safer supply. Rather than punishing people for their hard-earned resilience and survival skills, Safer Supply efforts should seek to understand how drugs are actually used in communities and to respectfully engage people from that understanding instead of a war on drugs mentality. Lesson 7 is that Safer Supply is just one part of a more equitable access to health and well-being. Number 8 is that participants engage better in Safer Supply programs when working with staff who have lived and living experience of criminalized drug use. Number 9 is that contempt, discrimination, stigma, and paternalism towards people who use drugs is a public health and human rights emergency, and we continue to see that in how people who use drugs, particularly people who are homeless who use drugs, have direct impacts on their health and ability to survive. And number 10 is that Safer Supply is not the answer to the toxic drug poisoning crisis. We need to see action towards decriminalization, legalization, regulation. This is one iteration that is needed, but it is not the panacea. And so the last thing that I want to leave you on before we open up for questions is that we here at the SAFER program acknowledge that our program exists within the same medicalized model that I've been highly critical of today. Capacity isn't nearly high enough to address needs. Barriers make programs like these very inaccessible to many. We know this, we sit with this discomfort, and we challenge barriers every single day in every way that we can. We need more prescribers out there assuming risk and challenging their own institutions if we're ever going to see real progress. This is artwork from a nurse that I work with. Her name's Anna Trowbridge, and this is shared with permission, as is this last one here that I'll leave up while people gather their thoughts for questions. I want to thank everybody for listening to me today, and very appreciative of this opportunity. And there will also be future opportunities for us to talk about other subjects, like next month when we will be talking about emotional harm reduction. Maybe I should unshare screen.
Thanks so much, Corey. That was fantastic. I'm going to pass it over to Alexandra to do the question and answer. I'm also going to stick a poll up if people could take, it should take like less than a minute to just do a quick poll for us. Thanks so much.
So I'll give people a minute or two to send their questions into the Q&A section. I've already got 4 or 5 for you, Corey, so get ready. I'm sitting here sort of like vibrating a little bit, and I'm not sure if it's because I'm nervous to be on a webinar or if it's because of your incredible presentation. So thank you so much. You always bring so much sort of nuance to the work that we do. So I am going to invite people, like I said, to put your questions and answers into that question and answer box. You can also ask them in French. Je peux les poser en français aussi. I'm going to start, Corey, if you're ready, with our first one. Is there anything available or different strategies out on the market that can reverse overdose effects that will interrupt the benzodiazepine in the fentanyl, since naloxone is not effective against it?
Yeah, that's a really good question. So like, I'll start off by saying benzo safe supply has probably been the least invested in and probably has the most risk aversion from prescribers for a number of reasons. And that is not to knock on prescribers, actually. They just recently were blamed for overprescribing and were basically blamed for the overdose crisis, and now we're asking them to prescribe lots. And so it can be very confusing kind of climate for people to work within. But at the SAFER program, what we've done is we've embedded a benzo withdrawal protocol into our program. So as people are using less and less street down, we can assess them for signs and symptoms of benzo withdrawal and actually prescribe them benzodiazepines as they continue to go through that process. In terms of responding to an overdose, and I know that was the main premise of your question, there's a drug that reverses benzodiazepine overdoses called Flumazonil. And it is a drug that I used when I work in the operating room for a couple of years because anesthesiologists chronically oversedated their patients. And it is an overdose antidote for benzodiazepines, but it's not the same as naloxone. Naloxone is less risky than a Tylenol or an ibuprofen. However, throwing someone into benzodiazepine withdrawal through the administration of Flumazonil can lead to seizures and death. And so I think it'll be very unlikely that you would actually see Flumaz kits like you see naloxone kits. Flumazonil, spell that. That's too hard, Natalie. Flumazonil, I think.
Thank you for that, Corey. Because we've only got about 20-25 minutes left, I'll go right to the next one. We have someone from Toronto. As a person who is on safe supply, as well as a person who uses drugs, I'm currently a relief consumption treatment services provider, and I see this very same thing you just talked about. So this was from much earlier on when you were speaking about what Nanki had brought up. Nanki saved my life, and without Nanki, I would be a statistic. I'm a chronic pain sufferer, and I have faced many barriers with safe supply. I hope to see one day where if you use drugs, you can go to a pharmacy and pick up what you need with no barriers. At what point do you see this becoming an actual reality?
Yeah, I mean, we need to see meaningful political courage towards decriminalization, and I'd encourage everybody to support Kapud's efforts in the legal challenges against the federal government in terms of challenging the harms of the ongoing prohibitive nature of our governments. We need to see an end to criminalization if we want to see that form of accessibility, but it's not as unimaginable as people think. I think people are quite afraid of opiates, but in truth, like I said, at one point in time, cannabis went through this awkward stage where doctors were prescribing it, and they all knew that they shouldn't be the ones prescribing it, and it didn't really fit there. But they needed to continue to push those boundaries so that we can now see opportunities where people can go into a dispensary, and all the dispensaries look like Apple stores to me now, but you can go in there, and if there's a bad batch, if there's a moldy supply or something, the regulators will remove that supply and will recall that supply. And the same thing is possible for opiates. And you look at nicotine replacement therapy as well, which is harm reduction for tobacco consumption. At one point in time, a doctor needed to prescribe you that, and it didn't make sense that it was there. And now in BC, at least, you can go to a pharmacy, you fill out a couple of forms, and then you're offered a year's supply of nicotine replacement therapy. And all of these things are imaginable for people. We just need to see more political courage, and we need to see more focus from our government. And I'm hoping when they're out of caretaker mode that we can apply the pressure even more.
Thank you. Next question is, again, this was from earlier on in the presentation. You mentioned that often kind of a reasoning against providing safer supply is that we're needing to research this more before we act, kind of as like an argumentation. The person asks, are there not examples from other countries that could be used? So I guess the question is, are there examples from other countries that could be used?
Absolutely. There's heroin assisted therapy programs that you can look at in Europe. You know, you can even take studies from Crosstown Clinic here in locally to see, but those are IOT models, and what we're looking for is to push beyond that. And as much as I'm, you know, in favor of things like IOT, people have to go to a program 3 times a day at set times. Their life becomes tethered to that program, and it's very hard for people to even, you know, go spend time with family or to try and engage in other activities. And so there will always be a need for those programs, but what we need really is something that hasn't been studied, which is giving people who use drugs the right to choose, and actually just trusting them with those medications and giving them carries. It's amazing even to see with the fentanyl patch program that we've been working with here in Victoria. It's a replacement for people's OAT, and now people, because it lasts 72 hours, they can get their patch changed on Friday and they can go camping for the weekend. That's like the first time that they've been able to do something like that, because it used to be that the doctor wouldn't trust you with the carry for your methadone, and so you could only at most do day trips.
For sure. Freedom. There's a lot of questions coming in. I'm doing my best. Hopefully we get through them. How did you recruit your doctors? It seems that they are, quote, too busy to talk about drugs. Also, the person is wondering if they may send some of your slides, which we will share after, to the Minister of Health and Addictions. She's in the process of consulting with the community.
Yeah, I mean, it's all publicly accessible. It's, if I shared it here, then it's shareable wherever you need it. And then there was the first question. Oh, doctors, right. You know, very fortunate. We work with an amazing group of physicians, and they truly, like, we talk about these uncomfortable tensions of addiction medicine and harm reduction almost on a daily basis. And when things feel uncomfortable, we hash it out together. And these are the same doctors. The SAFER program started in July of 2020, but I've been working with these same doctors since April of 2020, when the risk mitigation guidance documents came out for BC. And so they have a ton of trust in the nurses, because we've all basically moved through this whole pandemic together, and we've written the protocols together. And because everything is so protocolized, there's trust there, and we're very fortunate. And so, like, we try to do everything we can to make sure that we're supporting those doctors, because they are out in the deep end in terms of prescribing. They are heavily scrutinized by their colleagues. There's a lot of conservatism and regression in addiction medicine, and when people fall out of line, there's actually the intention to try to drag them back down instead of seeing progress in the profession. And so we, on top of doing things like making practice briefs and trying to do as much evaluation as possible, we also do things like put together audit packages for our doctors, so that if they are audited by the College of Physicians, that they have something that they can easily use and it's less onerous on them. And it's just about creating a practice of solidarity, really.
Excellent. Next question. Hi, Corey. Thanks so much for this wonderful presentation. I work in Ontario, and we have a lot of regulatory barriers to fentanyl products, i.e. they are not on our formulary, they need special permissions, etc. Did you have to overcome any of these issues in BC? Oh,
100%. Yeah, no, we have a very frequent dialogue with the Ministry of Health, particularly their pharmacy department. And we, everything like fentanyl tablets, fentanyl patches, sufentanil, all of that has to be acquired through a special authority. because it's not traditionally covered. And so, you know, we've created special authority templates for our doctors so that they're easy to submit. We've circled back to the ministry when the turnaround has been too long to get people approved. You know, we purchased enough ward stocks so that we can start people while the special authority process goes through, so that we don't have to ask someone to come back a week later. Because if you do that, they may never just come back. That week could be the difference between life and death for someone. And so we try to strike while the iron is hot. And as soon as they come in and they're ready to start, we get the process rolling right away. But it is a challenge. It's an ongoing challenge. You know, we're also looking at things like diacetylmorphine, inhalable diacetylmorphine, powdered fentanyl, powdered cocaine. All of these substances are, like, you know, not something that's been traditionally on a formulary and not traditionally under coverage. And so we have to do a lot of advocacy with the provincial government. But honestly, I'm going to eat my own words here. That both the provincial and federal government have not been barriers to us in trying to roll these things out. They legitimately want to see some traction and some success in these types of initiatives. They could do more to make it work, obviously, but they haven't been the barriers to us at this point in time.
Thank you for that. I think this is going to be a quick one. What is down versus opiates?
Well, down is just street lingo for opiates. Opiates are derived directly from the poppy plant, and opioids are synthetic versions of that. And on the street, people are usually just talking about down. And our clinic is very accessible, and so you know, like, we try not to get over medicalized, and so participants come up to us and say, can I get my next smash or whatever? That's our cue to get them their next dose. And so apologies for the colloquialisms.
How many people are served by SAFER in Victoria? If SAFER is a pilot, when can it become a program?
So that's why we developed these practice briefs, and that's why we wrote all of our prescriber guidance. So our the ways that fentanyl patches are prescribed, the fentanyl tablets are prescribed, the sufentanil is prescribed, the way that we operate and that we do flexible staffing models, all of that is made publicly available, because part of our mandate is to try and build capacity elsewhere so that more people pick these materials up and start doing it within their local community. The problem is that people are really afraid when you get into rural and remote spaces. If you're a doctor at 100 Mile House and you're the only doctor there and you start prescribing this way, you will be flagged for an audit way quicker than the 6 doctors that we work with here who have their own solidarity of practice. And so as we speak, there's more, you know, we're meeting with other health authorities who want to take on this type of prescribing. We're meeting with more municipalities who have medical officers of health who want to take on this type of prescribing. We've met with other provinces who want to take on this type of prescribing. And so that's part of our goal, is that we make it impossible for this to be a pilot study. We need to develop the evidence quickly. We need to see other providers pick it up. Because there's so much precarity in pilot studies, and they're actually quite deadly and harmful. And we spend so much time talking about what do we do if we get defunded, and how do we keep people supported, and how do we make sure they still have access to these medications, that if we didn't have that sword hanging over our heads, we could probably do even more work. But instead, it's about making sure we do what we do safely.
Thank you. How can we resist being sanitized of our radical social justice roots working within a medical model?
Again, I think it's about like having those conversations and challenging those structures every single day. We, you know, at SAFER, between staff meetings and physician meetings, we have difficult conversations every single day. And, you know, we have times where it's, you know, myself advocating and hitting a wall and trying to explain, and to the point where we've even sworn at each other before. But we all understand why we're having these conversations, and we all try to move through that together. And It's not about personalizing it. People get very, like nurses and doctors and social workers get very upset when you talk about the institutional and historic harms created by those different service providers. But in truth, you need to acknowledge it, and you need to have that in the room with you at all times, so that you can have those difficult conversations and acknowledge them, first and foremost, that this is not the perfect end goal where we're at right now, not by any stretch of the imagination. We're at a point right now where we're at capacity, and so we have a wait list, and we hate wait lists. People die on wait lists, and it's awful. And so then now we're talking about how do we build capacity with other service providers in Victoria, so that if we can't meet people's needs, how else can they access these products? And that goes against the way that governments precariously fund programs, because they want you to do it all and to report on it so that you can get your funding next year. And we need to also be more collaborative and make sure that we're building each other up so that this program lasts way beyond what a pilot study could manage.
I think that's a great answer. And I'll also add to that by replugging Nanki's webinar from last week that was literally about this topic. I think it's a great listen if you haven't had a chance. My colleague Robin popped the link in the chat there.
Yeah, cannot stress enough. Do watch that. Do watch that presentation. It's amazing.
Yeah. My work is focused on communities. Are there any sources, links that I can learn from to ensure I'm evidence informed and using appropriate, non-stigmatizing language?
Yeah, I mean, I think right there is part of the crux of the issue sometimes, is that we get really hyper focused on evidence-based practice, and we need to also, like, if you're community, then you need to be talking to people in that community who use drugs and hearing first and foremost from them and learning from them and learning the history in those areas. And every local context is different, but I would highly recommend that we're hearing firsthand from the source, and that we're adequately compensating people with lived and living experience of drug use, and that we're using their feedback and their experience in order to guide our practice.
I'm sorry to just keep barraging you, but we've got about 10 minutes left, so we'll see how far we can get, okay?
We're doing good, aren't we?
This question is from Steve. Hi, Steve. Are any of the fentanyl options you mentioned that you are offering it safer, meeting the needs, matching the tolerance levels that heavy fent users have now? What are some of the average doses, and what is the higher level of fent that people are getting prescribed? Also, what is the feedback on how similar the legal fent is to street fent?
Yeah, I mean, it depends on the program. So with the Fentanyl program, that goes up to about 200 micrograms per dose. People can get 4 doses a day as long as it's been at least an hour between doses. It's relatively short acting, but it's quite strong. And so it's about 5 to 7 times stronger than fentanyl. Like, we do tolerance tests with people when we talk to them, and we do witness consumption for the first couple of ones just to make sure that we're not dialing it up too high on people with their tolerance. And we've gotten some remarkable feedback from people. Like, we have people now who were on OAT and they're still on their OAT, but they like to use on top of that, and they liked that euphoria. And now they come to the clinics anywhere between 1 and 4 times a day. And they say that that's completely eliminated their I think my volume might have just cut out there for a brief moment here, but so it is comparable to the street with the Fentora tablets with the fentanyl pills. Those are the highest dose options for people. It's twice a day, or you can come in once a day if you only want to come in that one time. It lasts 4 to 6 hours. We're working on offering people options to smoke it, because there's anecdotal evidence that it is a smokable pill. And that goes up to 2,000 micrograms of fentanyl twice a day, which is quite high. And lastly, with the fentanyl patch, the highest we have someone on is 1,200 micrograms of fentanyl, which is 12 100 microgram fentanyl patches. And we have people who are now telling us, people who are using a ball a day or a half ball a day of pretty potent stuff, who are telling us, they're like, man, I went and smoked a dragon and I couldn't feel it because it's a stupid patch. And we're like, oh, that's actually pretty cool. And so there's been a huge reduction. You know, we've got people telling us, like, I can work now. It used to be that I, you know, would be within the first hour of working and I'd have to go off and hide somewhere and use. And now I can go the entire stretch of my work without having to use. And so it's hard to gauge because, like, the drug volatility is so vast that, you know, it's such a wide range. It's hard to tell. Sometimes we're not even close to hitting the mark with people, even with our highest doses. And sometimes people are at 500 micrograms on a fentanyl patch and they tell us, you know what, I'm good. I want to stay at this dose. So it's very individualistic. It's very much about everyone's individual tolerances. It's about the rituals and the ways that they like to use their drugs. We can offer people combinations as well. So it's not just one intervention. You can be on a fentanyl patch plus a short acting like a sufentanil or a fentanyl tablet. And on top of that, you can still get your oxys or your Dilaudid. So, like, we've got options for the whole 24 hours. Plus, people can come in and do an injection if they want to use a little bit extra. And then when the clinic closes, if they don't want to use any street supply, they've got their Dilaudid or their oxys to carry them through the rest of the day. And we try anything and everything that the participant asks us if we can give it a go. We try to honor that autonomy.
Okay. And along with that question came, does anyone mix different options? And then I think also connected to that question is if you could talk a little bit more about people smoking oxycodone as a harm reduction technique and what brands are often prescribed in doses as well.
Yeah, I mean, I think I answered the question about mixing fentanyl options. Yeah, you just can't be on multiple of the same. So you couldn't be on Fentora tablet and sufentanil injectable. You'd be like on one short acting, one community-based prescribing, which is the Dilaudid or oxys, and one long-acting, which could be KD and methadone, but it could also be a fentanyl patch. And you can pick and choose from each of those three streams in order to have your needs met. What was the other question? Sorry.
It's okay. If you could speak a little bit more about the smoking of oxycodone.
Yeah, I mean, like, prior to fentanyl hitting the street, when I was working as a street nurse, we had people who told us that they were able to smoke their Oxycodone, and even when Oxyneo changed, and everybody who thought that was a smooth decision, I had people within the first 2 weeks who were telling me that they figured out how to cook the new Oxyneos and how to smoke it. And so when we first started developing the program and we consulted with people who use drugs, there was a consensus that Oxycodone would be a viable option for people to smoke. There's no randomized control trials or peer-reviewed articles about the smokability of oxy tablets, and so a lot of it has been centered based off of the feedback of people who use drugs. But it also is super convenient because oxy immediate release 20 milligrams is also covered in BC, and so it wasn't an issue of money. And the 20 milligrams IR is almost identical morphine equivalents of the Dilaudid 8 milligrams. And so converting that and changing people between options was really easy as well. And so it was a bit of a no-brainer that we would give it a go. And I would say probably over 50% of the people who receive community-based prescribing are on the oxys and are reporting benefits from it.
I'm going to ask you one more question, and I hope it can be a quick answer because we're running out of time. People are wondering if nurse practitioners can prescribe as well, and like who in the nursing field can prescribe.
Yeah, nurse practitioners can prescribe. We've considered exploring that option a couple of times. There's not a lot of nurse practitioners in Victoria, but there's definitely more in the downtown east side. And I know of some in the north BC and in the downtown east side who are prescribing safe supply. It's even more hostile territory for a nurse practitioner to be kind of going rogue and prescribing this way if the broader physician community is not interested in it. And so I've actually had a couple of individual sessions with nurse practitioners in rural and remote areas who want to do this type of prescribing but didn't know how to do it. And so we've kind of like shared all of our protocols and tried to bring them into our community of practice.
Okay. Thank you so much. I'm going to welcome Rebecca back on, and thank you infinitely, Corey, for your excellent webinar. I just want to assure people there were a number of questions that we just cannot get through. We have copied and pasted those, and we hope to be able to provide you with some resources and some answers for those questions as well. As I mentioned before, we will be sharing the webinar recording, Corey's PowerPoint, any resources that were shared in that PowerPoint, and any important resources that came up in the chat. Rebecca, I'll pass it off to you.
Thanks, Alex. You basically just said the things that I was going to say. But I also just want to give a reminder to people that we do have our website. And if you are interested in joining the community of practice so that you can access member-only events as well as these public events, then please register. Even if you already think you're a member and you're on our mailing list, we need you to register through our website so that we can continue to give you access for members-only events. So upcoming public events, Corey's coming back on November the 8th with Akia Munga, and the discussion there is going to be about emotional harm reduction. So it's November 8th from 1 to 2:30, that's Eastern time. And please register in advance. You can register through our website. Also, Gillian Cola will be presenting on the Safer Opioid Supply Program Evaluation at London Intercommunity Health Centre. That's November 25th. And again, you can register through our website. Some upcoming member-only events and some of the resources that we have for members only. We have a prescriber panel. It's going to dig a bit deeper into these tensions of providing a medical model of safer supply from a harm reduction approach. We have some role-specific workshops that we're going to be offering probably in January. We're still scheduling those. So if you're a program coordinator, if you're a program RN, if you're a pharmacist, if you're a client or a participant of a safer supply program, we'll have a workshop that's specific for each of those roles and more, prescribers as well. We have a bunch of working groups, including on topics such as diversion, interdisciplinary teams, access to pharmaceuticals. We also offer consultation and support. And one of those activities, consultation activities, does include a prescriber consult line that we will be launching on October 25th. So for more information, do check out our website and feel free to reach out to myself and the team. And Corey, big thanks for being here today to do this presentation. It's been really important to us to have you come in and talk about these tensions and possibilities, because that really is setting the tone for the community of practice. And also let me give my thanks to Gabrielle for the French translation. Thank you so much for that hard work. And Alex and the rest of our team, I'm grateful for the team that we have that's making these webinars happen, and grateful for all of you for participating. Thanks so much.